Great, so welcome to our university seminar series with the GW Institute for Brain Health and Dementia on addressing dementia across the public health spectrum. Today we have a wonderful speaker, Dr. Laura Zahodne. Dr. Zahodne is an assistant professor in the Department of Psychology at the University of Michigan. She trained in clinical neuropsychology at the University of Florida, the Alpert Medical School of Brown University, and the Columbia University Medical Center. Dr. Zahodne's research program aims to understand how life course psychosocial experiences influence late life cognitive trajectories, the expression of neurodegenerative disease, and racial ethnic inequalities in Alzheimer's disease. Her research group collects a longitudinal biopsychosocial data from large, representative, and diverse cohorts, including the newly established Michigan Cognitive Aging Project. Dr. Zahodne also co-directs the Michigan Center for Contextual Factors in Alzheimer's Disease, a National Institutes on Aging funded resource center for minority aging research that aims to grow the workforce and infrastructure for research on dementia inequalities. And today she is going to speak on biopsychosocial pathways in dementia inequalities. So thank you very much, Dr. Zahodne. Take it away.
Yeah, thank you so much for that introduction, and thanks for the invitation. Let me share my screen and you can tell me if you see it. Let's start my slideshow. All right, so I'm excited to share with you this aspect of my research program that approaches a major public health and health justice issue of dementia inequality from a biopsychosocial perspective. So I'll start today just by giving some super brief background on racial inequalities in dementia. I'll spend most of my time talking with you about some studies that my lab has conducted to look at potential explanations for these inequalities that persist even after we control for some of the usual suspects in health disparities research. I'll take some time to talk about a couple of challenges to this work. These are not challenges that are unique to research on dementia inequalities, but they seem to be particularly crucial to consider in this area. And then I'll end by talking about some of my ongoing data collection efforts in Michigan to minimize some of these challenges and to further this line of research. So I'm sure that you know that the global population is aging rapidly. And what this means is that there are more and more people at risk of Alzheimer's disease and related dementias. So right now there are more than 6 million people just in the US living with AD, and that number is projected to double over the next 20 years. But what pictures like these don't convey is who these people are. So this disease, like many, is not randomly distributed in the population. It differentially affects marginalized populations, including certain racial ethnic minority groups. And to show just how disproportionate dementia rates are across race ethnicity, here I'm showing a study led by Elizabeth Rose Maeda that used data from the Kaiser Permanente Managed Care Health System in Northern California to estimate differences in incident or new onset cases of dementia across these 6 racial and ethnic groups. And as you can see, African Americans, who are shown in the purple line, are more likely to develop dementia than other groups, such as non-Latino whites and Asian Americans. And while this particular data set was limited in its ability to identify the specific causes of these differences, there's a growing body of evidence for the social determinants of these group differences that overwhelmingly shows that they represent a health inequality. So a health inequality is a particular type of health difference that is avoidable, unnecessary, and unjust. And importantly, these group differences persist even after we control for a lot of the usual suspects in health disparities research, things like socioeconomic variables like education and income, but also health variables, cardiometabolic diseases like diabetes, heart disease, diseases that have long been known to differentially affect marginalized groups. So what are some of the potential explanations for these inequalities that persist despite adjusting for those important known mediators? Well, first, we probably aren't routinely measuring all of the risk factors for dementia in our cohort studies. there may be risk factors that privileged groups simply aren't exposed to, and therefore haven't been routinely measured or considered in research that uses largely white samples. Another possibility is that the dementia risk factors that we do know about might exhibit differential impact across race and ethnicity. That is, having a particular risk factor may be more or less risky for members of a particular group. So I'm going to show you some studies now demonstrating both of these possibilities, starting with the first one. So these next data come from the Health and Retirement Study. This is a large nationally representative study of adults over 50 in the US. It's run out of the Institute for Social Research at the University of Michigan. And for this study, we focused just on those who were 65 and older at the time that a comprehensive psychosocial battery was added to the HRS in 2006. And in this study, we were interested in testing this specific theoretical model of psychosocial pathways involving reported experiences of discrimination. So the psychosocial variables that we included were ones that previous research had hinted were important for minority cognitive aging, but they hadn't yet been put together into a comprehensive model examined across multiple racial groups or used as joint predictors of longitudinal cognitive change. So here, the discrimination measure captures the frequency of everyday experiences of interpersonal discrimination, which we conceptualize as a potent form of social stress. And qualitative work has suggested that these social experiences can result in changes in mood, as well as an increase in the perception that one is really not in control of his or her life outcomes. And we confirmed that this model fit the data better than alternatives, and we estimated all possible associations. For simplicity, I'm just showing paths that were significant in the final model, and I'm not showing the demographic, socioeconomic, or health covariates. So compared to whites in the HRS, non-Hispanic Blacks reported more discrimination, which in turn predicted both depressive symptoms and external locus of control. And both of those psychological consequences of discrimination were, in turn, associated with lower initial memory performance. And in addition to those pathways to initial memory level, discrimination also directly predicted steeper rates of subsequent memory decline. So these data suggest that discrimination may be a central node in psychosocial pathways leading to worse memory for older Blacks and ultimately greater dementia risk. So that's an example of a psychosocial model of racial inequalities. In my lab, we've been trying to extend this work into a biopsychosocial model by investigating some of the physiological mechanisms by which psychosocial experiences may get under the skin to affect health. So here we incorporated longitudinal biomarker data available in the HRS, specifically levels of C-reactive protein measured in capillary blood. So C-reactive protein, or CRP, gives us a measure of systemic inflammation. And we know from prior work in both animals and in humans that inflammatory markers, including CRP, are elevated in the context of chronic stress. So this study used all the available HRS data to test whether elevated CRP mediates longitudinal associations between everyday discrimination and episodic memory. Now, we didn't see a whole lot of intra-individual change in this 4 to 6 year period, and there was no longitudinal mediation in these data, but we did see evidence for mediation within the baseline data, where we had a lot of inter-individual variability. Specifically, those participants who reported more frequent experiences of everyday discrimination had higher CRP, which in turn was associated with lower memory performance. So some preliminary evidence that inflammation may represent one pathway by which racially patterned social stress could influence memory performance. But in addition to studying how the experience of discrimination gets under the skin, we're also interested in how it might get into the skull. So these next data come from the Washington Heights Inwood Columbia Aging Project, or YCAP. And this is a longitudinal epidemiological study that follows a regionally representative sample of older adults living in northern Manhattan. And about 1/3 of the YCAP sample identifies as non-Hispanic Black or African American. And this is the group that I focused on for this study of discrimination and brain aging. So a subsample of the non-demented participants in YCAP have undergone 3T MRI, and this study used available data from 2 MRI time points that were separated by about 3.5 years. And recently we added a psychosocial module to YCAP in order to help us understand these different causes of racial ethnic disparities. And that battery included multiple measures of discrimination. And the inclusion criteria for these analyses were self-reported race ethnicity of non-Hispanic Black, the availability of at least 1 time point of usable neuroimaging data, as well as psychosocial data, and the absence of dementia at the time those self-report psychosocial measures were completed. So these are data that were just accepted at the Social Science and Medicine, showing that Black participants who experienced more racial discrimination showed lower hippocampal volume at baseline. So this discrimination measure here that I'm showing on the x-axis is a little different from the one that I talked about before. So this measure queries specific experiences of racial discrimination in major life events that could have happened at any time over the life course. So this would include discrimination in education, in the labor market, in housing. Some examples were, have you ever been unfairly prevented from moving into a neighborhood because the landlord refused to rent you an apartment due to your race? Or have you ever been unfairly denied a bank loan due to your race? So unlike the other measure, which asks questions about everyday experiences of interpersonal discrimination, this measure is tapping into life course experiences of more systemic racism. But we also included the other measure of discrimination that taps microaggressions or kind of interpersonal discrimination. And there we found a longitudinal association between that measure of racial discrimination and white matter hyperintensities. White matter hyperintensities are an indicator of subclinical cerebrovascular disease. So specifically, Black participants who reported more everyday discrimination showed faster accumulation of this pathology over time. So here, time is on the x-axis, and the 3 different lines correspond to model estimated trajectories for an individual reporting high, average, or no everyday racial discrimination. And as you can see, white matter hyperintensities increased among individuals who reported high levels of everyday racial discrimination. Now again, this measure queries current, ongoing day-to-day experiences of interpersonal discrimination. Some example items are how often have other people treated you with less respect due to your race, or how often have you been called names or insulted because of your race? So an interesting potential take-home message from the study relates to the fact that these 2 different measures of discrimination were associated with different brain outcomes, and that might point to different mechanisms. So specifically, this measure of day-to-day experiences of interpersonal racism appeared to be most relevant to the ongoing accumulation of white matter hyperintensities, which might point to cardiovascular and inflammatory pathways implicated in chronic stress. But in contrast, the accumulation of major experiences of systemic racism across the life course appeared to be most relevant to baseline hippocampal volume, which might suggest that the experience of racial discrimination in major life events has a stronger influence on hippocampal development and maintenance leading up to late life than on hippocampal atrophy during late life. So that baseline association could reflect neurotoxic effects of stress on the hippocampus, but it could also reflect the long-term impact of systemic racism on life course opportunities and environments, which could affect brain health independent of stress. So as just one example, racial discrimination in housing could result in greater lifetime exposure to air pollution or other environmental toxicants that are known to be particularly deleterious to the hippocampus. So I think there's a lot more work to be done in this area. And recall that another potential explanation for persistent dementia disparities is that risk factors might disproportionately affect outcomes among certain social groups. And I'll talk about differential impact of two risk factors in particular: depressive symptoms and white matter hyperintensities. So for this next study, we used data from the norming study for the NIH Toolbox. The Toolbox is a standardized set of computerized neurobehavioral measures that was developed through the NIH Blueprint for Neuroscience Research. And that norming study included individuals from age 3 to age 85 living throughout the US. But for this particular study, we focused just on a relatively small subsample of participants who were 55 and older. And we found that even though Black older adults in this sample reported fewer depressive symptoms than whites on average, when depressive symptoms were present, they were more strongly related to lower cognitive performance among Blacks. And here are some pictures demonstrating these different associations. And these results are consistent with literature showing that depression, though often found to be less prevalent among Black adults, has also been found to be more chronic and to have a greater functional impact among Black adults. And this might be because non-Hispanic whites are more likely to have access to situational and environmental advantages and resources that buffer against the negative health impacts of depression. And conversely, membership in a minoritized group is associated with situational and environmental disadvantages that could compound risk. And we've since replicated these results in a couple of different data sets. But this differential impact appears to exist not just for psychological risk factors like depressive symptoms, but also biological risk factors. So here I'm focused on white matter hyperintensities, and using data from YCAP, we see that white matter hyperintensities are more strongly associated with worse cognition in multiple domains. So here I'm just showing you the comprehensive language factor among Blacks than among whites in YCAP. And again, we think these group differences could reflect interactions between white matter hyperintensities and environmental variables that are racially patterned and that are important for cognitive resilience. So in other words, advantages afforded to the majority group might not only protect against the accumulation of white matter hyperintensities, but might also buffer against their negative cognitive impact. So up to this point, you've seen that a lot of my research has focused on modifiable risk factors that help to explain racial inequalities in brain and cognitive aging. But this association between race, this complex sociocultural construct, and cognitive aging reflects the sum of both risk and resilience pathways. So one implication of this is that the racial differences that we're measuring in our cohort studies may actually underestimate the health risks of social inequity, because different social groups also cultivate norms and behaviors that can be health promoting. So focusing only on risk can't tell the whole story. And I'll give you some examples now of studies that show the value of focusing not just on risk, but also resilience in the study of health disparities. So this next study comes from the Health and Retirement Study. Again, these are data suggesting that religious involvement may represent one naturally occurring source of cognitive resilience for many Black and Hispanic older adults. So this work was led by a recent graduate from our lab, Serena Krall, who was interested in parsing this multidimensional construct of religious involvement into different components: the strength of religious belief, the frequency of attending formal religious services outside the home, and the frequency of praying privately. And she examined how these three aspects of religious involvement differ across racial and ethnic groups and how they relate to memory. So here I'm going to show paths in her statistical model that were positive and significant. And I'm not showing her comprehensive set of covariates. But as you can see, both non-Hispanic Black and Hispanic participants in the HRS reported higher levels of all three of these components of religious involvement, consistent with previous research. And two of these components, private prayer and attendance, were in turn positively associated with episodic memory. So even though these two racial and ethnic groups exhibited lower memory performance overall, those disparities, shown in red, were offset by these independent resilience pathways, shown in green. So I think this line of work really highlights the need to partner with communities to understand the cultural values, norms, and practices that are already in place, especially when we think about meaningful intervention research. Here's another example of the value of considering both risk and resilience in studies of racial disparities. This comes from a recent paper led by a graduate student in my lab, Emily Morris, in collaboration with a former postdoc at the Institute for Social Research here at Michigan, Dr. Lauren Brown. And Emily was interested in replicating and extending Dr. Brown's critical work on stress appraisal and mental health to cognitive health. And together they showed that Black older adults in the HRS reported being exposed to more chronic stressors than whites. And in turn, being exposed to more chronic stressors predicted worse cognitive health. So there was this negative indirect effect involving stress exposure that contributed to the overall total effect, showing a Black-white disparity in memory performance. But those Black older adults also appraised stressors as less upsetting than whites, showing evidence of adaptation that may reflect different historical and contemporary lived experiences and coping. And while appraising stressors as less upsetting didn't moderate the negative impact of stress exposure on memory, there was no interaction between these two stress variables, there was a main effect such that appraising stressors as less upsetting predicted better memory. So similar to the set of results I showed you on the last slide, the Black advantage in stress appraisal offset the memory disparity. This provides evidence for both risk and resilience among Black older adults. So next I want to spend a little bit of time talking about some of the major challenges to this work. So while these are challenges to many types of research, I'm going to hopefully show that they might be particularly challenging to research on inequalities in aging outcomes like dementia. So the first challenge relates to selective survival, which refers to the fact that socially disadvantaged groups, including African Americans, who are a focus of this particular paper, show higher mortality early on in the life course. So what this means is that those who survive to late life and make it into our dementia cohort studies exhibit greater physical and or mental resilience that enabled them to survive. So in other words, they are more heavily selected than non-Hispanic whites. And one implication of this is that we see a narrowing of racial disparities at later ages, in part because you're comparing this increasingly selected African American group to a less selected white group. And we've shown this in both midlife and late life cohorts. The younger members of your sample are likely to show the largest disparities, in part because there has been less time for this mortality selection to take place. So importantly, not only does selective survival affect the magnitude of group differences observed in older samples, but it also undermines causal inferences. So I personally love this empirical demonstration of survival bias that uses smoking as the example. So this graph here summarizes many prospective epidemiological studies that have examined the association between smoking and incident AD. So each circle here corresponds to one study. And what you can see is that those studies that initially enrolled relatively younger individuals, like age 55 and 60, showed that smoking predicted increased risk of Alzheimer's disease. Whereas those studies that initially enrolled and followed relatively older individuals showed the opposite. They showed that smoking predicted decreased risk of Alzheimer's disease. Now, we don't believe that once you hit age 75, you should take up smoking to ward off dementia. In other words, those negative studies don't reflect causal associations. Rather, if you survive to age 75 or 80 dementia-free, despite being a lifetime smoker, you probably have some sort of unmeasured, possibly genetic resilience, and the risk marker, smoking, becomes a proxy for that unmeasured resilience, and it sort of masquerades as a protective factor. So selective survival is one reason why many studies, particularly those interested in dementia inequalities, are recruiting younger participants, in contrast to more traditional dementia cohort studies that recruit 65 plus, and the mean age at study entry is around age 75. So selective survival is one challenge to disparities research in aging. Another is recruitment. So a recent demonstration of the implications of recruitment for dementia disparities research can be found in this paper by Carrie Gleason and colleagues, who looked at Black-white differences in dementia conversion in data from NAC, the National Alzheimer's Disease Coordinating Center. So this study included over 33,000 participants who were recruited from 37 Alzheimer's disease research centers throughout the US. And as you can see in this graph, when examining just those individuals who were initially cognitively healthy, there were, surprisingly, no racial differences in conversion to dementia. And when examining just those individuals who met NAC's criteria for mild cognitive impairment, or MCI, at enrollment, Black participants showed less conversion to dementia than white participants. So these findings are in stark contrast to Dr. Maeda's study that I showed you at the very beginning, as well as currently available meta-analyses of mostly population-based studies that estimate the dementia conversion is at least 60% higher in Blacks than whites in the US. But if we take the NAC data at face value, we might conclude that there are no racial inequalities in dementia. But what's great about this paper is that the authors note some important differences between whites and Blacks in the NAC dataset that suggest that these results might be an artifact of selection bias. So specifically, they note that increasing efforts to diversify ADRC cohorts have led to divergent recruitment strategies targeting different racial groups. So while most of the white participants in NAC are presenting to these tertiary care clinics with memory complaints, most of the Black participants in NAC are recruited directly from the community. So just as one example of how we can quantify this, more white participants in NAC were referred by a health professional. And that variable, being referred by a health professional, was in and of itself a unique predictor of dementia conversion. And the problem here is that these divergent recruitment strategies can introduce selection bias when the recruitment strategy, here community-based versus clinic-based recruitment, is associated with both the grouping variable, in this case race, and the outcome variable, in this case cognition. So as depicted in this figure, this is because clinic-based samples, shown in gray, are enriched for people who are at increased risk for Alzheimer's disease. Whereas community-based samples, shown in cream, have a more average risk for Alzheimer's disease. And if whites are disproportionately recruited from the higher risk clinic population, and Blacks are disproportionately recruited from the average risk community population, then we aren't going to be able to obtain valid estimates of racial differences in dementia risk. Now, this bias is difficult to overcome statistically, which to me highlights the need for new data collections, for new studies that were explicitly designed to examine health inequalities, as opposed to retrofitting a lot of our existing studies to become studies of health disparities. So when I came to the University of Michigan, I wanted to launch a new study that was specifically focused on health inequality from the beginning. So in 2017, which feels like only yesterday, we started recruiting people into the Michigan Cognitive Aging Project, which now follows a regionally representative, racially balanced cohort of adults transitioning into late life. And we recruit for participants from Washtenaw and Wayne counties here in Southeast Michigan. So here I'm showing the location of the University of Michigan in Ann Arbor, as well as the city of Detroit, where many of our participants live and work. So in MCAP, we use a direct mail recruitment strategy that takes advantage of socio-demographic data from the US Census and mailing addresses from the voter registration list. So our initial address-based sample included over 5,000 adults aged 60 to 65. We were really happy to see a response rate of over 10%, which is more than the 3 to 5% response rate that's typically reported in the literature for this kind of direct mail recruitment strategy. And in the background of this slide, you can see the racial distribution of residents in the Ann Arbor, Ypsilanti area in Southeast Michigan. So whites are shown with blue dots and blacks are shown with green dots. So these are the kind of data that we use to guide our sampling strategy, which ultimately resulted in our only targeting census tracts in the city of Ypsilanti at the far right of this picture for our Washtenaw County recruitment, as well as census tracts within the city of Detroit for our Wayne County recruitment. So we wanted to maximize the representativeness of our sample, so we implemented very minimal inclusion-exclusion criteria. And while we initially planned on limiting enrollment to individuals in the address-based sample, we chose to respond to our enrolled participants' overwhelming requests to refer people that they knew. So not only did we want to be responsive to participant preferences and foster mutual collaboration with the community, we also saw this as a way to systematically study recruitment and enrollment factors. So individuals who were ultimately recruited via this chain referral are clearly identified in the data set. And interestingly, our preliminary analyses show that those referred participants have lower socioeconomic status and poorer health than the address-based sample. And this is consistent with the original conceptualization of chain referral as a recruitment method to help identify and recruit populations that have been historically underrepresented in research. We also wanted to eliminate one of the many barriers to research participation, which is transportation. So we allow participants the option of being seen in their homes or in research space, either in Detroit or in Ann Arbor. So in MCAP, 1 in 5 participants opts for a home visit. And we think that has really helped us achieve a more representative sample. We also make our biomarker sub-studies optional. So far about 83% of people have agreed to provide a blood sample when asked. And about 67% of people have been both willing and eligible for neuroimaging. And we're particularly invested in retention. So for every participant, we collect contact information for at least one person who would be expected to always know their whereabouts and who doesn't live in their home. We also create and send annual newsletters to maintain contact with participants and encourage updating of contact information. We just finished our first follow-up visits with participants, which take place 2 years after enrollment. And so far, our retention of survivors has been close to 85%, which we think is pretty good for this population. So this is a really busy slide with basic information about the first 500 participants enrolled in MCAP. The pie chart at the upper right is the racial ethnic breakdown. So as you can see, MCAP is largely a racially balanced sample of non-Latino Blacks, shown in orange, and non-Latino whites, shown in blue. We are aiming for a racially balanced sample rather than mirroring population demographics, because we want to maximize power for between group analyses and within group analyses. So in MCAP, we don't see racial differences in basic demographic factors, but we see moderate to large socioeconomic disparities across all metrics, as well as moderate to large physical and mental health disparities. Now, the kind of primary outcome of interest in MCAP is cognition. So here you can see our neuropsychological battery, which can be adequately summarized by these 5 latent variables. We chose a lot of these tests to harmonize with other studies, including NAC, with some changes like including a color trails test instead of the traditional trail making test to accommodate lower literacy levels. And in addition to these traditional paper and pencil neuropsych tests, we also give most of the cognitive measures from the NIH toolbox, including their reading test. So, as I've said, one of the primary goals of MCAP is to advance understanding of cognitive disparities. And here you can see those disparities. They're prominent in the unadjusted data. So on average, Black participants score more than 1 standard deviation lower across our battery compared to white participants. These disparities are somewhat attenuated in the demographically adjusted data. So this graph controls for age, sex, and the heavy hitter education. And through a variety of ongoing projects, our lab is really dedicated to more fully characterizing the pathways that create and sustain these disparities, with a particular focus on psychosocial factors and their biological mechanisms. So MCAP is one new cohort that I'm excited about. Another is the Detroit Aging and Memory Project, or DAMP. So through this project, we were recently funded to obtain the very first dementia prevalence estimates among older Arab Americans, which is a group that has been virtually absent from research on dementia and a lot of other health outcomes, which is due largely to the fact that the US government legally classifies Arab Americans as non-Hispanic white. This is despite evidence that Arab Americans have been increasingly racialized and subjected to various and unique forms of both interpersonal and institutional discrimination since 9/11 and the initiation of the War on Terror. So this region, just west of Detroit, has long been home to the most concentrated and visible population of Arabs outside of the Middle East. So here I'm representing the city of Dearborn, Michigan, with the logo for the Arab American National Museum, which is located there. So DAMP, after a very painful COVID delay, is scheduled to go into the field this summer using a state-of-the-art sampling and recruitment strategy that was designed with the Survey Research Operations Group at the Institute for Social Research here at the University of Michigan. And we aim to recruit a population representative group of Arab Americans age 65 and older to ascertain dementia prevalence. We're using a battery of cognitive and functional measures that we have translated into Arabic with the help of many community partners. And based on available evidence for high prevalence of dementia risk factors like diabetes and depression among Arab Americans, we believe that there may also be disproportionate rates of dementia in this group. And making those disparities visible would highlight the need to disaggregate this invisible group from non-Hispanic whites, which very nearly happened with the 2020 census, when recommendations to add a Middle Eastern, North African, or MENA demographic category were ultimately not enacted. That change could have really facilitated high quality research on health inequality and other types of inequality, and hopefully will happen with the next census. But in the meantime, we're invested in this primary data collection with this community. But talking about facilitating research on health inequalities, I'm also super excited about our relatively new NIA-funded Resource Center for Minority Aging Research in Michigan. This is MCFAD, the Michigan Center for Contextual Factors in Alzheimer's Disease. And our center focuses on contextual factors. And some of the activities that you all might be interested in include our summer data immersion program, where scholars from across the US can come to Ann Arbor and learn about leveraging public data resources for research on ADRD and minority cognitive aging. We also have a competitive enrichment program that provides mentoring and pilot funding to junior faculty or mid-career faculty who wish to transition into research on dementia inequalities. So keep an eye out for our annual requests for applications to both of these programs. And our other center activities include developing participant registries to facilitate AD research with Arab Americans in Southeast Michigan, as well as Latinos in West Michigan. So through all these efforts, we hope to develop the research workforce and infrastructure for research on dementia inequalities. So I want to end and give us time for questions by acknowledging all of the participants in the studies that I work with, not all of which I was able to present on today. I also want to thank some incredible collaborators at the University of Michigan and Columbia University, as well as generous funding from the NIH and from the University of Michigan. And I'll end with this call to action and an image of our virtual lab group based in Ann Arbor. And thank you again for the opportunity and for your attention. I'm excited to take your questions. Thank you.
Thank you, Dr. Zahodne, for such a great presentation. What awesome information. Maybe I'll kick off a question. I'm really interested in this concept of resilience, balancing out some of the other psychosocial factors. How are you planning to tease out resilience as part of your DEMP and NCAP study?
Yeah, I think resilience is understudied, but I mean, for good reason. I think if we're interested in eliminating disparities, we should think about what the risk factors are that we can eliminate. But the idea that there may be resilience factors there that might not necessarily balance out the risk factors, but at least offset them somewhat, provides yet another avenue for intervention. So we focused on risk factors for a long time. We haven't made a lot of progress in reducing inequalities. And I think the main advice to someone wanting to think about resilience factors as they pertain to racial and ethnic disparities is to collaborate with community partners in order to really identify what are the naturally occurring or already in existence resilience factors that we may be underestimating or that we haven't yet studied, because they may be those that are easiest to intervene on because they're naturally occurring in the population, and we may be able to develop more culturally responsive interventions if we target those resilience factors that are already in use in a lot of the community. So we have really extensive psychosocial batteries in MCAP and in DEMP. We're asking a lot of questions about life course psychosocial experiences. And we really do try to balance our questionnaires between asking about risk factors and stress and financial factors with potential resilience factors, particularly those related to social relationships and coping. So that's sort of another aspect of my research program that I didn't talk too much about today, which is social relations and cognition, and kind of decomposing that multidimensional construct of social relations into more actionable elements. So what is it about social relations that may be most protective for cognition? Is it the number of people in your social network? Is it the composition of people in your social network, family versus non-family? Is it how frequently you talk with them, or is it how much support you get from them? I think we kind of have this notion that social relations are good, but that's not super actionable. We really need to figure out what is it about social relations that are good in order to have more targeted and effective interventions.
Maybe I'll go out on a limb with a question. So you talk about looking at blood markers and kind of the physiology behind psychosocial factors. I'm seeing more about epigenetic and heritable changes that happen because of chronic stresses or life events like events of racial injustice and isolation and I'm forgetting some of the others, but are you seeing some heritable factors effects in your research, or what are your thoughts on that?
Oh, that's a great question. Yeah, so I'm not much of a geneticist. I haven't measured any genetic or epigenetic elements, but I think that's a really promising area of research. I've seen a couple of really cool papers showing real evidence of the intergenerational transmission of trauma. So I think that is an area that we need to study more. From the kind of more self-report side, there's in parallel been some really exciting developments in research that's looking at social stressors and discrimination occurring not at the individual level, but kind of at the larger level. So measures of vicarious discrimination, so the extent to which you observed discrimination occur to people within your social network, or even occur to people that you don't know. So, with kind of the increasing accessibility of images through social media, thinking about violence against Black people being so easily accessible on social media, that's another form of vicarious discrimination that we're starting to see has effects not just on the people who are involved in the event, but those who are witnessing it sometimes over and over again through the news or through social media. So I think, we can measure that physiologically, but I think we're also measuring it now more in using our self-report measures, so that we're not just focused on the individual level anymore. We're looking at not just individual, but social networks, as well as kind of more global at a higher level too. That's a great question.
Fascinating, thanks. Well, seeing no more questions, thank you so much, Dr. Zahodne, such great information. We will have one more event for the seminar series. This will most likely be a panel discussion. More details to come, so stay tuned. Please check out our website at brainhealth.gwu.edu and stay engaged with us. Thank you all so much for attending, and thanks again, Dr. Zahodne.
Thank you.